Okay. Shall we start?
Okay. Yeah.
All right. Good morning, everybody. My name is Miroslav Radenkovic. I'm coming from Belgrade, Serbia. I'm professor of pharmacology. I'm not cardiologist, so be gentle to me today. And I'm going to talk about the clinical pharmacology of sotagliflozin, novel quality in treatment of heart failure. At the beginning of this lecture, I would like to, underline that I have no conflict of interest, although I'm going to talk about a new drug that I believe is going to be really novel quality in the treatment of heart failure. So, we all know that heart failure is a serious clinical syndrome with symptoms and signs provoked by structural and functional cardiac abnormality and coupled with elevated natriuretic peptide levels and evident pulmonary or systemic congestions. However, when we speak about pharmacotherapy, about the novel pharmacotherapy, we know that heart failure is still a really big problem in the regular treatment. And regardless of outstanding improvements in the management of heart failure over the past period, its prognosis is still poor, with notable rates of mortality and hospitalization due to worsening of overall clinical presentation. So, the data from groundbreaking clinical trials are demonstrated that the beneficial effects of SGLT2 inhibitors are really here, are really present, and we need to pay attention about this new group of drug that is initially developed in the treatment of type 2 diabetes mellitus. However, it shows some very promising promising effects in the future adjacent treatment of heart failure. So, in this matter, the sotagliflozin was recently registered as a SGLT2 inhibitor prescribed to reduce the risk of cardiovascular death, hospitalization for heart failure, or urgent heart failure in adults with heart failure or type 2 diabetes mellitus, chronic kidney disease, or other cardiovascular risk factors. Please note that this drug was not initially developed for the treatment of type 2 diabetes mellitus, and it doesn't have still approval for this indication. So it was specifically developed for the treatment, for the adjacent ancillary treatment of heart failure. So the main objectives of this presentation will be to clarify pharmacological features of sotagliflozin. So I really like to work with the clinicians because I know that they need the help from the clinical pharmacologists. And I'm also a bioethicist, and this gives me a specific perspective in reviewing and approving the clinical trials that are coming to our research market. And I hope this pharmacological approach will provide some better understanding of this new pharmacological drug for the heart failure. So let's start with the beginning. So diabetic medications known as sodium glucose transporter 2 inhibitors work by preventing the reabsorption of glucose in the proximal renal tubule, which causes glucose to escape into the urine and lower serum levels. So this is the basic mechanism of actions of most of the drugs from this group. However, some pleiotropic actions were found in the middle, of this developing process, and that's why we are talking about sotagliflozin today. SGLT2 pharmacotherapy has been increasingly documented to have important ancillary benefits, including those related to cardiovascular system. That's why we are so much interested in this group of drugs, because we can see substantial reduction of weight, substantial reduction of vascular resistance, uric acid. We have some very promising effects of myocardial SGLT1 transporter. Oxidative stress is reduced, blood pressure, and so on and so forth. So this type of drug can be something that we need in some adjacent therapy of heart failure. If we are talking about this type of group, about these drugs, unlike insulins, they are secretagogues and sensitizers. SGLT2 inhibitors divert glucose to urine, causing a daily metabolic wasting of up to 500 kilocalories, which is quite substantial result if we are talking about about patients with increased cardiovascular risks, which offers us an insulin-independent mechanism for restoration of euglycemia. You can see from the right side of this slide some of the drugs that are on market now, like canagliflozin, dapagliflozin, epagliflozin, and so forth, which are in the group of type 2 antidiabetic agents with the target mechanism of action of forced glycosuria at the proximal tubule of kidney, with substantial reduction of glycosylated hemoglobin up to 1%, with reduction of weight, reducing of hypoglycemia, and stabilizing the blood pressure. What is important for this presentation is that clinical trials have shown that there is substantial cardiovascular safety of these drugs with proven randomized clinical trials like EMPA outcome, Canvas, Declare-TIMI, and so forth. However, this group of drugs show some common unwanted effects, which gives us opportunity in question to assess the risk-to-benefit ratio. Can we use these drugs, and will these drugs are going to be effective and safe for use? If we are looking for the time span of the FDA approvals from 2012 to 2017, several drugs from different pharmaceutical companies were approved, like dapagliflozin, canagliflozin, empagliflozin, and so forth. But what was the common thing? I think the unwanted effects, the side effects, or adverse drugs reactions, as we are pharmacologically speaking, were there, like dehydration, ketoacidosis, urinary tract infections, vaginal infections, some were hypoglycemia infused with insulin and secretagogues and sensitizers, and so forth. However, when we assess the risk-to-benefit ratio, we can see that the relative risk and benefit profiles of SGLT2 therapies based upon randomized clinical trials is rather favorable than not, because we see some common unwanted effects like genitourinary infections, postural hypertensions, slightly increased risk of diabetic ketoacidosis, and for some drugs, even the risk for the lower limb amputation. But this was a rare side effect. But on the right side of the slide, we have some clear benefits to prescribing SGLT2 inhibitors, and I told you some of them are here, and I didn't mention reduction of cardiovascular and cardiovascular death risk, chronic kidney disease and diabetic kidney disease risk reduction, as well as end-stage kidney disease and cardiovascular event reduction. So that makes us at the position that we can expect some good pharmacological things from this type of drugs. If we are talking about the cardiovascular effects, so we can see the time span which is related to heart failure in specific. So we can see in 2018, FDA approved canagliflozin to reduce the risk of heart attack, stroke, or cardiovascular death in adults with type 2 diabetes mellitus and established cardiovascular disease. After that, in 2019, the FDA approved canagliflozin to treat diabetic kidney disease and reduce the risk of hospitalization of heart failure in diabetic patients and so forth. In 2020, we can see that the FDA approved dapagliflozin to reduce the risk of cardiovascular death and hospitalization from heart failure in adults with heart failure with reduced ejection fraction. What is important is that in 2021, there was a first update of American Cardiac College guidelines for SGLT2 inhibitors used in high heart failure with reduced ejection fraction. In 2022, FDA approved empagliflozin in the JASON treatment of heart failure with preserved ejection fraction, which resulted in updating the current guidelines from ACC in regard to SGLT2 inhibitors used in heart failure with preserved ejection fraction. And finally, in May 2023, sotagliflozin was approved in the US. So this little heart, combines all that we need from one drug to be, effective in specific indications like the type 2 diabetes mellitus, accompanied with, kidney disease, accompanied with cardiovascular risks, accompanied with heart failure. So in type 2 diabetes, cardiovascular disease, major adverse cardiovascular events are going to be reduced, and in renal disease, it's a reduced decline of estimated glomerular filtration rate. However, we can see that pharmacologically speaking, which is very important for us for the future use of these drugs are not the same. So canagliflozin has the lowest oral bioavailability as opposed to ertugliflozin with the highest oral availability. Also, the selectivity towards the SGLT2 and 1 was not the same. So we can see that dapagliflozin, empagliflozin, and ertugliflozin are purely selective SGLT2 inhibitors, while canagliflozin and our sotagliflozin have been shown to have weak selectivity for SGLT2 over SGLT1. So it's very important because in contrast to SGLT2, SGLT1 receptors are especially expressed in the myocardium. So we are going to see in the future, especially from the basic pharmacological research, how this is going to reflect to the efficacy of the therapy. If we are talking about SGLT inhibitors in specific context to heart failure, when added to regular therapy, SGLT2 inhibitors significantly reduce the composite outcomes of cardiovascular death and hospitalization from heart failure. And canagliflozin was the most effective in this way of speaking, followed by sotagliflozin and so forth. But the analysis focusing only on heart failure-specific trials identified sotagliflozin as the most likely agent to reduce cardiovascular death and heart failure hospitalization, followed by empagliflozin and dapagliflozin. So, again, I'm stressing out that I have no conflict of interest. Maybe I will, but today not. So sotagliflozin is a drug being developed by Lexicon Pharmaceuticals to treatment of heart failure, including heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. In May 2023, it received its first approval in the US. As we're talking about the chemical structure, the basic chemical structure resembles to all the members of the group, having one glucose ring and having one proximal and having one distal benzene ring connected with a methylene bridge. Sotagliflozin acts as an inhibitor of both sodium glucose transporter 1 and 2. And what is important, that inhibition of SGLT1 reduces intestinal absorption of glucose and sodium, while SGLT2 inhibition results in reduced renal reabsorption of glucose and sodium. So very nice mechanism of action. However, while the exact mechanism of the cardiovascular benefit is still under investigation, decreasing renal sodium reabsorption can help reduce the cardiac preload and afterload and sympathetic activity. So what are the FDA-approved indications? So first, cardiovascular risk reduction, including reduction of cardiovascular mortality, hospitalization for heart failure, and urgent heart failure visits in adults with type 2 diabetes, chronic kidney disease, and other cardiovascular risk factors. As for the heart failure, risk reduction of cardiovascular mortality, hospitalization for heart failure, and urgent heart failure visits in adults with heart failure. So the dosing regimen is quite simple. We are giving by mouth once daily dose, starting with 200 milligrams and increasing after 2 weeks, if necessary, to 400 milligrams max. Pharmacokinetics is something that we should always be aware of when we are talking about any type of drug, especially if we have this new drug on the table. So if we are talking about maximal bioavailability in 400 milligrams, it's around 25%. It's not that bad, since the contribution of enterohepatic circulation to the overall exposure is estimated to be approximately 50%, and the median time to maximum plasma concentration is ranging from 1.5 hours to 3 hours. However, it is recommended that sotagliflozin cannot be taken more than 1 hour before the first meal of the day, because we learned from the clinical studies that high-calorie meal will increase the available concentration of sotagliflozin in the circulation, which will disturb, what we need from the therapeutic action of this drug. Sotagliflozin is over 93% bound to plasma protein, but in clinical terms, this is not so much of importance, because so far results didn't obtain some indications that drugs with high affinity to plasma proteins will actually push out sotagliflozin from previously bound proteins and increase the available concentration. It is mainly metabolized by the glucuronization through the uridine diphosphate glucurosine transferase family, and to a lesser extent with cytochrome P450 family, 3 subfamily A. The most important thing from this slide is that it is not so metabolized by the cytochrome enzymes, which means that it will not go to the many of drug interactions with other drugs that are metabolized in the same pathway. So following the administration of single dose, we can see the 57% will be found in feces, while 57% in urine, as it is very important for the basic mechanism of action, and the 37% in the stool. Contraindications. So first, some hypersensitivity, if any, but patient on dialysis and those with the reduced volume, we are not recommended that, especially if the estimated glomerular filtration rate is under 30 mL. And we need to assess the volume status, and in patients with volume depletion, we need to correct this condition before initiating the drug. And it is not recommended in the patients with type 1 diabetes mellitus, because many of clinical investigations showed us that there is diabetic ketoacidosis on the corner waiting for this type of drugs. So we need to be very careful. We know that reports of ketoacidosis, a serious life-threatening condition, require urgent hospitalization and have been identified in clinical trials and post-marketing surveillance in patients with type 1 and type 2 diabetes who received the SGLT2 inhibitors, including sotagliflozin. And some fatal cases of ketoacidosis have been also documented, but they were rare and not with sotagliflozin. And if ketoacidosis is suspected, sotagliflozin should be discontinued. The patient should be evaluated and proper treatment should be instituted. And the treatment of ketoacidosis may require insulin, fluid, and carbohydrate replacement. And we need to monitor patients for the resolution. Volume depletion. So we need to be very careful, especially with elderly patients on loop diuretics, and because before initiating sotagliflozin, we need to assess the correct volume status in patients with impaired renal function or low systolic blood pressure. Sotagliflozin can also cause what we call intravascular volume contraction, which may sometimes manifest as symptomatic hypotension. And we need to monitor signs and symptoms of hypotension. What is very common in the randomized clinical trials with the SGLT2 inhibitors, there have been reports of serious urinary tract infections, including urosepsis and pyelonephritis, requiring hospitalization. And so we need to evaluate patients for signs and symptoms of urinary tract infection and treat promptly if necessary. We have some more precautions and warnings. Hypoglycemia, we need to consider lower dose of insulin and other anti-diabetic drugs when used in combination with sotagliflozin. And what is, something unexpected, but it was there with, several members of this group, necrotizing fasciitis of the perineum. This is a serious, life-threatening cases, have occurred in both females and males treated with SGLT2 inhibitors. We need to assess patients presenting with pain or tenderness, erythema, or swelling in the genital or perineal area and treat promptly. As far with the genital mycotic infection, we also have cases with patients who have history of genital mycotic infections. And adverse reactions are here, and they are, extracted from the precautions and warning: urinary tract infections and genitourinary fungal infections, volume depletion, diabetic ketoacidosis in patients with type 1 diabetes, hypoglycemia with concomitant use with insulin and insulin secretagogues, and necrotizing fasciitis of the perineum. As for the drug and food interactions, this is quite favorable pharmacological profile that we are having, since sotagliflozin does inhibit P-glycoprotein, weakly induces cytochrome enzymes and a minor substrate for the cytochrome enzymes in liver. However, I said before, high-calorie meal increases sotagliflozin bioavailability and should be administered not more than 1 hour before the first meal. So we don't have so many proved interactions because of the inhibition of P-glycoprotein. Sotagliflozin may increase serum concentrations of some drugs. The co-administration of rifampicin, an inducer of cytochrome enzyme systems with sotagliflozin, results in decreasing exposure of the sotagliflozin. We have to remember that rifampicin is inducer of microsomal enzyme system in the liver, so it will enhance the metabolism of this drug. Concomitant use with lithium may decrease serum lithium concentration, and as previously said, sotagliflozin may enhance the hypoglycemic effect of insulin and sulfonylureas. When we are talking about specific population, not so many clinical results. We have lots of preclinical results. pregnancy is not, sotagliflozin is not recommended in lactation, or not recommended in pediatric use. We don't have any reports yet. In geriatric patients, we need to be very important to the cases related to volume depletion, as previously said. In renal impairment, higher incidence of adverse reactions related to the reduced renal function. And we are talking about the liver function. It can be used if we are not talking about moderate or severe hepatic impairment. We don't have an antidote, so we employ the usual supportive measures for the overdosage. We can contact medical toxicologists for additional overdose management, and removal of sotagliflozin by hemodialysis has not been studied yet. Where are we going now in the future? So this is not finished story with sotagliflozin. Before coming to Paris, I wanted to try to find the newest clinical trials to present to you to see what is going with this drug. And I found 4 clinical trials, of which 2 are in the phase of recruiting, and 4 are not even yet recruiting, and there is one clinical investigation which is important for us in consideration to heart failure. But let's see what's going on. So I will give just one slide for all the clinical studies, just to see what's going on. I'm stressing out that this drug is not approved for the type 2 diabetes. It was developed for the heart failure. So we are now, making some progress in this matter as we are talking about type 2 diabetes and chronic kidney disease. So this is the study called sotagliflozin to slow kidney function decline in persons with type 1 diabetes and diabetic kidney disease. And we can see that we are going to give sotagliflozin against the placebo to see in the conditions of diabetic nephropathies, kidney failure, chronic, and diabetes mellitus type 1, to see if we can decline the slowing of the kidney function. So I won't go into the specifics. But the next one is very important. So this is sotagliflozin in heart failure with preserved ejection fraction. We know that clinical benefits of the dual sodium glucose transporter 1 and 2 inhibition have been recently reported in 2 clinical trials. In 1 clinical trials, it was reported some benefits of sotagliflozin in type 2 diabetes mellitus patients hospitalized for worsening heart failure, while in other clinical trials involved with 2 type 2 diabetes. It's worth noting that not only did the event curve separate within the first week post-treatment, but the effects of sotagliflozin on heart failure-related outcomes were, visible and observed regardless of left ventricular ejection fraction values, and did not seem to attenuate with increasing left ventricular ejection fraction as seen with empagliflozin and other drugs. So the present study aims to investigate the potential cardiorenal pleiotropic effects of sotagliflozin in mechanistics, randomized, double-blind, and placebo-controlled trial in heart failure patients with preserved ejection fractions, and comparisons between treatment groups will be made using cardiac MRI, cardiopulmonary exercise test, 6-minute walk test, and Kansas City cardiomyopathy questionnaire. And I will go through other studies just to read what is going on. Ambrisentan, sotagliflozin, and prevention of renal injury. and then combination adjunctive therapy to address multiple metabolic imbalances in type 1 diabetes, and the prevention of chronic kidney disease progression in type 1 diabetes with the long-term use of sodium glucose cotransporter inhibitors, avoiding kidney hypoxia. This is very important study, and I would say the last one is maybe groundbreaking because we are, examining the sotagliflozin safety and tolerability among renal transplant recipients. So this is an investigator-initiated randomized controlled trial in adults with stable allograft function and terminal kidney disease, and we want to see, the reversibility of the expected acute changes of the estimated glomerular filtration rate with sotagliflozin and proportion of patients completing the protocol according to different estimated glomerular filtration rate reporting strategies, and 3, safety and tolerability of sotagliflozin. So as a primary outcome, we are, we want to see what are the reversibility of estimated glomerular filtration changes. Following 12 weeks of open label drug treatment, participants will stop and followed by other 4 weeks. And reversibility will be assessed as the proportion of patients who return to baseline estimated glomerular filtration rate by the end of the 4th week of treatment period. So, I'm reaching the end of this presentation. What we see is that the scientists, that the clinical trials have found that SGLT2 inhibitors can be introduced in several time spans of the treatment of chronic heart failure. They are now into, official ACC guidelines, and the last revision was in 2022. This is just one of the possible algorithms, starting with ACE inhibitors and or ARBs and beta blockers, and going to mineralocorticoid receptor antagonists, and then, through the assessing of the clinical status. While on the right side of the slide, you can see that SGLT2 inhibitors can be involved, and we are hoping that sotagliflozin is really something that will going to improve the overall therapy. As the conclusion, so sotagliflozin approval for heart failure and cardiovascular risk reduction appears to represent a significant development in the utility of SGLT mechanistic agents, specifically for the use of the heart failure. Sotagliflozin does not carry approved indications for either type 2 diabetes or chronic kidney disease alone versus other already available approved agents. And this approval and the evidence cited by FDA appear to cement its role in the management of heart failure of all types and has already been cited in the most recent American College of Cardiology 2023. This is an expert consensus decision pathway on the management of heart failure with preserved ejection fraction. So I really hope that this lecture was useful for you, and I hope that we are going to have all the advancements in the heart failure. And for more information, you can visit my ResearchGate account, and I would like to cooperate with you if you would see some possibilities. So please, you can make additional contact through the provided email address. So thank you very much for your attention.